No, that's already finished. Yeah, that's the one. Good morning, everyone, and greetings from Cochin. Subscapularis is often, quite often, neglected. That's why probably it is cornered into the last portion of the meeting. I don't know, but things has to change. I'm going to dedicate this to the Indian Army, where you can see what happened recently, and they are making it safe. And the top picture is from Indian Army came to Kerala to rescue during the worst flood last year. Now, why the debate? Quite often it is neglected. Why? Probably it's the mindset of people. It's quite difficult, probably. That's what people think. But if you look at the biomechanics, subscapularis has got its own merit. It plays a large role in the biomechanics to keep the joint reaction force and the equilibrium of the joint. Probably that is the only anterior stabilizer of the joint. It's a 45 to 53%, looking at the paper, of the total cuff strength is by the subscapularis. It's often untreated. That can lead to failed cuff repair, however good you are repairing your supraspinatus and infraspinatus. And that will lose automatically the patient satisfaction as well. But if you look at the incidence of subscapularis, you can get an isolated subscapularis tear, which is rare, but usually it is associated with one of the other cuff, usually the anterior cuff, which is the supraspinatus, anterior leading edge of the supraspinatus. Now, why it is under diagnosis? Probably it is due to the difficulty in testing, due to the painful shoulder. And none of these tests are very robust in diagnosing the subscapularis. That may be the reason, mainly for the pain inhibition. Reliability of the test is questionable. That's why. But if you look at what is the subscapularis functionally doing? Is the anterior cuff. Anterior cuff is functionally the leading edge of the supraspinatus, long head of biceps, and the subscapularis. That forms the unit of the anterior cuff. Clinical diagnosis is by history and recurrent instability after 40 years, previous open surgery. All these things you need to be a bit aware of when you diagnose. MRI finding, most often you can see the subluxating in long head of biceps, and you can see sometimes the fibers has been ruptured there. It cannot be sometimes very accurate as well. That's the problem. So it may be associated with the supraspinatus tear. Okay, there are other indicators which I am not usually incorporating in my clinical practice. I don't think many of you. So it's the most important thing is the subluxation of the long head of biceps. That's what we are looking for. But the important thing is arthroscopic assessment. When you do arthroscopic assessment, then you know what you're seeing. And that is how we are. There are arthroscopic classification as well, which I am not going into the details. What you can do is when you do the arthroscopy, you do an internal rotation and external rotation and see the whole of the subscapularis. I do under the V chair position with the general anesthetic and a block. And you can see the subscapularis. I'm looking at the subscapularis. See, it's all frayed up there. So once you clear off all these things, the debris, you can see what is happening to the morphology of the tear. Okay, what you are looking for is the footprint of the subscapularis, which is obviously the lesser tuberosity. So I'm coming with my radiofrequency ablator and cleaning it off to see what is happening to the footprint. Okay, now once that is cleared, it's easy to come with the anchor from the anterior side. I usually do a single double-loaded anchor and easy to repair through the anterior side. You can see that my anchor is going there. That's a wedge anchor from Stryker. Okay. So you can see there I am using one of the suture passing technique. You can see I have loaded my suture and it's just pressing and it's coming through. It's expressive from my deck. You can see that it's a pass through and I'm taking it out. That's a double load anchor. So you can see the striped one next to the one I have taken the bite. Okay. So I think it's the repetition. It's the same. Okay, I will go to the next slide. Yes. Okay. So that is the second suture as well, and I'm going to put the sutures now. All through the anterior portal. Okay, now this is one I did last week. You can see the long head of biceps is subluxated medially. So that's why you can see it clearly. The footprint can be exposed clearly on the lateral side of the lateral to the long head of biceps. Okay, and you can see a large cuff tear, supraspinatus and infraspinatus. So that make my life easy because I can come through the lateral side as well to do my suture manipulations. Now, you can, I'm coming from the lateral side, so I don't have to damage any more cuff. It's already done there naturally. So I'm putting my anchor. That's from the anterior portal. It seems that on the lateral side of the long head of biceps, but once the repair is done, the long head of biceps will be back in position. I will run through that video. It's only 2 minutes, so I got time. Okay, there I'm using a bird beak. Sometimes you'll have to dissect out. If it's completely retracted, you have to resect out up to the coracoid. And you can put a soft tissue grabber and take it back, just like your tendon. Okay, it will come out. But be careful. Okay, so that is the first suture gone through. And I'm going to suture it back onto the, you can see my suture coming up there. Onto the footprint. You can see that automatically the long head of biceps has gone into its position. I don't unnecessarily do a biceps tenotomy there because there's nothing wrong with the biceps there. So I just left it alone. Okay, you can see that is the subscap back in position. Okay, so usually is neglected. I think it's the mind block, the mental block people are having because it's going to be difficult. No. But remember, if you leave the ruptured subscapularis alone, you will have a failed rotator cuff tear because most of the load of the anterior cuff, the main anterior cuff is the subscapularis, and that's the single dynamic stabilizer on the anterior side. So subscapularis, where we stand now, 15 years ago probably we just left if you see a subscapularis however big, we just would have left it alone. But now everyone has got a very low threshold to repair it. We know the biomechanics. You just probe the tendon, diagnose it arthroscopically, do internal external rotation, and the internal rotation will open up the subscapularis, and that will definitely, repairing it definitely will improve the biomechanics. I'm inviting you everyone for the 5th edition of a Sunrise ShoulderCon, 24th to 26th in Sunrise Cochin. 24th is the pre-conference workshop. I will encourage all the consultants to send your juniors there. That is for the juniors for the basic arthroscopy. Thank you everyone for wishing my daughter's marriage occasion, which happened last month.